Hello, thank you for joining us for Silencing the Noise, New Insights into Tinnitus, a webinar presented by the American Otological Society and the Korean Otological Society. To kick things off, Dr. Brad Kesser, Education Director for the American Otological Society.
Good evening to you on the East Coast and the Midwest. Good afternoon to you on the West Coast, and good morning, Korea. I'm thrilled to welcome all of you to this joint international webinar on tinnitus, sponsored by the American and Korean Otological Societies. My name is Brad Kesser, and I'm the Education Director of the American Otological Society. I'm joined by my colleague, Dr. Jae-Jin Song from the Korean Otological Society, and together we are proud to present Silencing the Noise, New Insights into Tinnitus. Before we begin, I'd like to welcome and introduce the presidents of the American and Korean Otological Societies, Drs. Nancy Young and Shine Park. Dr. Young?
Welcome, everyone. Thank you for joining us. I'm Dr. Nancy Young, President of the American Otological Society. I'm a surgeon scientist dedicated to childhood hearing loss at Lurie Children's Hospital of Chicago, an affiliate of Northwestern University Feinberg School of Medicine.
Hello, everyone. It is my great pleasure to welcome all of you to this first webinar of American Otological Society and Korean Otological Society. I'm Dr. Shine Park, President of the Korean Otological Society, and I'm also a professor and director of the Tinnitus Hearing and Balance Center at Seoul St. Mary's Hospital, the Catholic University of Korea.
I have a few words to share with you about the American Otological Society. We are a senior society of leading clinicians and scientists in the United States. The AOS was founded in 1868, and our mission is to improve the lives of individuals across the lifespan suffering with ear-related disorders. I invite you to visit our website to learn more about our society, including our support for basic science and translational research, and where you can access our webinar series, including a conversation with Francis Collins, former director of NIH, and renowned musician Huey Lewis about hearing loss and the brain.
Well, I'm going to introduce the Korean Otological Society. Founded in 1990, the Korean Otological Society is dedicated to advancing human ear health. And our society comprised more than 2,000 members who are actively engaged in research and clinical work aimed at improving ear health, including tinnitus.
I'm delighted to inform you that this is the inaugural collaboration between the American and Korean Otological Societies. Cross-pollination of ideas is essential to improve hearing healthcare. We look forward to future collaborations with our esteemed Korean colleagues.
And today's webinar on tinnitus marks the first official academic exchange between AOS and KOS. I'm confident that it will provide a valuable opportunity not only to strengthen the friendship between our two societies, but also to share knowledge, experience, scientific insights, and most importantly, hope for a cure for tinnitus. Thank you for joining us, and I wish you an enjoyable and fruitful webinar.
Thank you, Drs. Young and Park, and thank all of you for joining us for what promises to be a fascinating and up-to-the-minute discussion on the latest advances in our understanding of tinnitus. This webinar is being live captioned on our AOS website, AmericanOtologicalSociety.org. And following the talks by our four panelists, there will be a live question and answer period, a time for you to ask questions of our experts. If you are watching on our YouTube channel, simply type your question into the chat when you're ready. The questions will be curated by past AOS President, Dr. Sujana Chandrasekhar. Before we begin, let us know where you're watching from and what you hope to learn from today's presentation. So tinnitus is easy to define, but can be very challenging to treat, as we all know. To start, tinnitus is any perceived noise in the absence of external sound. Tinnitus is described as bees, described as bells, crickets, many different sources of tinnitus. I think it's important to remember that tinnitus is a symptom and not a disease. There are many, many different causes, and perhaps the most common cause is hearing loss. In this older National Health and Nutrition Examination Survey, you can see how the prevalence of tinnitus tracks with hearing loss. As patients get older, there's a higher prevalence of hearing loss, and as patients get older, there is a higher prevalence of tinnitus. If tinnitus does indeed track with hearing loss, this World Health Organization chart of the prevalence of hearing loss over time predicts that we will be seeing many more patients with tinnitus in the future. You can see on the left the global trajectory of hearing loss to 2040, and on the right, a series of graphs looking at regions of the world and the prevalence of hearing loss over time, and the World Health Organization's prediction of the prevalence of hearing loss. And so if hearing loss is going to explode over the next 20 years, we'll be seeing lots more patients with tinnitus. Incidence rates of tinnitus range from about 1%, according to this 2022 study, with prevalence rates of 14%. That's 740 million people worldwide. Clearly, the prevalence of tinnitus increases with age. As many as a quarter of the population over the age of 65 complain of tinnitus. And of those, 2%, or 120 million people, are affected more severely. And it's these patients that I hope we can address and that I hope we can really help in the future. Among our military service men and women, interestingly, tinnitus ranks #1 as the most frequently claimed and compensated service-connected disability, with 3.2 million veterans receiving disability compensation for tinnitus. As a result of this, the Department of Defense is invested in tinnitus, having spent over $46 million in research funding for tinnitus since 2008. Tinnitus, as we all know, can have significant effects on quality of life. And to understand the effect of quality of life on my patients, I generally ask my patients 3 questions. Number 1, does the tinnitus keep you awake at night? Number 2, does the tinnitus awaken you from the middle of the night, awaken you from sleep in the middle of the night? And number 3, during the day, if you're busy, you're running your errands, you're doing your thing, can you ignore the tinnitus? The patients in whom tinnitus seriously affects their quality of life are often caught in the tinnitus cycle. Tinnitus causes stress, the stress increases anxiety, the anxiety only makes the patient focus on the tinnitus even more. So the more you hear it, the louder it gets, the louder it gets, the more you hear it. And that all is related to stress and a stress response. And as a result, in conclusion, many different treatments and treatment strategies for tinnitus have been proposed and studied, but it is important to know that there is currently no cure for tinnitus. So one of our jobs as clinicians is to help patients manage their tinnitus. And for that, we turn now to our panel of experts. Can we see tinnitus in the brain? Dr. Jae-Jin Song, professor of otolaryngology and director of the Department of Medical Resources at Seoul National Hospital, will deliver a talk entitled, "It's Not Your Ears, It's Your Brain, the Neuroscience of Tinnitus." Now, if you have a question for Dr. Jae-Jin Song during his presentation, please type your question into the chat on our YouTube channel. We'll get to the questions at the end of the webinar. Dr. Song, thank you for being with us.
Thank you, Dr. Kessar, for your kind introduction. I'm Jae-Jin Song from Seoul National University. My title is a small provocation. It's not your ears, it's your brain. If you live with your tinnitus, you may regard it as a problem coming from your ears. Tonight, I want to show you why the real story is one floor up in the brain. Tinnitus is closely associated to hearing loss. In this classical German study of nearly 300 patients, the pitch of tinnitus matched almost exactly the frequency of maximum hearing loss. And of course, this indicated the relevance of hearing loss for the generation of tinnitus. However, tinnitus does not seem to come from the cochlea. Surgeons have actually cut the cochlear nerve to completely disconnect the ear from the brain to switch off tinnitus. And very often, tinnitus simply stayed or even worsened. If the sound truly came from the ear, removing the ear should end it, but it didn't. So, if not the ear, then where? Over the past decade, our multinational group has looked directly at the brains of people with tinnitus across many imaging studies. The consistent finding summarized here is that the brain activity of people with tinnitus looks measurably different from someone without it. The fingerprint of tinnitus is in the brain. Then the question is, why does the brain do this? To answer that, here's something surprising about how we perceive external stimuli. For centuries, we picture the brain as a passive receiver on the left panel. The world comes in, the brain reads it. But that's probably wrong. The brain is far too slow and the world is too noisy for that to work. Instead, it works like the figure on the right. It actively anticipates what's out there, then uses the sense to check. Perception isn't reading the world, but it's anticipating it. This is the central idea. The brain is a prediction machine. At every moment, it generates a prediction of what's out there, tests it against incoming sensory signals, and revises it. In other words, what we experience is a controlled hallucination. If you take a look at the loop, the brain sends a top-down prediction. That's the hallucination generated from the inside. The senses send bottom-up evidence. That's the control, anchoring it to reality. What you perceive is where the two meet. Even now, your brain is probably constructing my voice, and the sound at your ears is holding it to reality. Now, let me show you an example of controlled hallucination. This is the famous checker shadow illusion. Look at squares A and B. A looks clearly darker, and B looks clearly lighter. The truth is, they are exactly the same shade of gray. On the right, I've joined them, and you can see they're identical. Your brain knows B sits in shadow, so it predicts B should be lighter and overrides the raw image to show what it expects. That's a controlled hallucination. Tinnitus may be the same process happening in the ear to compensate for the lost auditory input to your brain. So, where in the brain does the phantom sound come from? In patients with little or no hearing loss, tinnitus lines up with the auditory cortex, the hearing part of the brain. But with more severe hearing loss, the brain's memory system is involved. That is, the more hearing you lose, the more the brain recruits memory circuits to generate the percept, namely tinnitus. And here's the clincher. There are people born completely deaf in one ear. That ear never sent sound to the brain, so the brain never built a memory of what it should sound like. And with no memory, there's nothing to predict and nothing to miss. The result? These ears never develop tinnitus. Tinnitus appears only if the brain has learned to expect sound. In other words, no auditory experience, then no tinnitus. The same mechanism appears across the senses whenever input is lost. In touch, it's phantom limb pain. The brain still feels the missing limb. In balance, it's Maulde-Bachmann syndrome, sickness of disembarkation. After a sea voyage, the brain continues to perceive motion on stable ground. And in vision, it's visual snow, a constant flickering static, and 6 in 10 of those patients also have tinnitus. One brain, probably one mechanism. A prediction, filling a void, occurs different senses. Why does this matter in the clinic? If the phantom comes from the brain, the best treatment acts on the brain, not the ear alone. 3 broad strategies. First, restore the input. Hearing aids and cochlear implants partially restore hearing, so the brain no longer needs to fill the silence. Second, retrain the response. Sound therapy and approaches like tinnitus retraining therapy or cognitive behavior therapy teach the brain to stop attending to the phantom. And third, modulate the circuit. Neuromodulation, such as repetitive magnetic stimulation, targets the overactive networks. The goal is not to silence the ear, but to recalibrate the brain's prediction. To wrap up my talk, the brain doesn't merely receive the world. It predicts it, and the senses keep that prediction honest. What we experience may be a controlled hallucination. When a sense falls silent, the brain fills the void with a prediction of its own, and that is tinnitus, with its analogs in touch, balance, and vision. The source of tinnitus is the brain, not the ear. Thank you very much for your attention.
Thank you, Dr. Song. And remember, if you have a question for Dr. Song or any of our panelists, please type it into the chat on our YouTube channel. Before we go on to our next speaker, let's take a moment to say hello to some of the folks watching. I am amazed at the number of people who have issued comments. People from Michigan, Washington State, Florida, Alabama, Louisiana, Italy. Several people have shared your experiences with tinnitus. In fact, one specifically said a noise exposure, an event that exposed him to noise triggered the tinnitus. I think we all agree or understand that occupational and recreational noise exposure is a major risk factor for both hearing loss and tinnitus. Argentina, Barcelona, Boston, Massachusetts, California. It's just amazing. And I think it's emblematic of the widespread nature of tinnitus and how people truly suffer with tinnitus and are looking for not so much cures perhaps, but ways to manage their tinnitus. And Dr. Song, there are several people in the chat that agree with you that it's not from the ears, it's from the brain. It's some signal generated from the brain. So really appreciate the comments. Louisville, Kentucky, many patients are online watching our tinnitus webinar, and truly, I hope you'll take away 1 or 2 pearls from our expert panelists. So it's now my pleasure to introduce Dr. Gail Whitelaw. Dr. Whitelaw is clinical professor and director of the Audiology Clinic in the Department of Speech and Hearing Sciences at The Ohio State University. Dr. Whitelaw will discuss collaborative care in tinnitus, the partnership between audiologists and otologists. And again, if you have a question for Dr. Whitelaw during her presentation, just type it into the chat on our YouTube channel. We'll get to the questions at the end of the webinar. Thanks for being with us, Dr. Whitelaw, and please go right ahead.
Thank you, Dr. Kesser. I'm happy to be here tonight, and I hope to be able to talk about something that's been very important to me in working with tinnitus patients, which is the interdisciplinary care primarily involving otology and audiology. So tinnitus, as I just mentioned, tinnitus treatment should be interdisciplinary. And my focus will be on that partnership, but the patient is the center of the partnership. And there are 2 critical aspects of any treatment that anyone works with, which are providing hope and giving help. There's a myth that many patients talk to us about, that they were told there was nothing anyone could do to treat their tinnitus. And as Dr. Kesser said earlier, there's no cure yet, but we're making some progress on things that are very, very helpful and can change the course of a person's tinnitus. So there's a lot of overview approaches to tinnitus management by audiologists. We need to assure that the patient's concerns are heard. They may have difficulty concentrating because of their tinnitus, difficulty with sleep. They may have difficulty focusing. They'll often say they can't hear over their tinnitus. It's a speech and noise issue, but it's an internal noise, and it affects the quality of their life. And the goal of any tinnitus management from an audiological perspective is habituation, which means the brain needs to relearn, as Dr. Song just talked about, to classify that ringing, buzzing, hissing, humming, whatever sound they have. The brain needs to understand that that's not an important sound, so it fades into the background. And the tinnitus in treatment may or may not change much, but what changes is how often it's noticed, how emotional the reaction is, and what kind of intrusive feel that it has. So beginning with validation tool is really important for anyone working with a tinnitus patient. And this is able to assess tinnitus distress. So in addition to what Dr. Kesser was talking about, it also adds some things that are in a validated tool to either look at how distressful it is or to measure some of the success in treatment. So there's 3 questionnaires that we use in our clinic: the tinnitus handicapped inventory, the tinnitus functional inventory, and the tinnitus reaction questionnaire, all of which are available free online. So because I work in a university and I'm a clinical scientist, we look at evidence-informed treatment for success in tinnitus treatment. And much of the research talks about the fact that the combination of cognitive behavioral therapy, or CBT, and sound treatment is the winning combination for creating a successful model. I'm going to talk to you about the model we use in our clinic, but there's lots of other options that are out there. So we use cognitive behavioral therapy tools that support that habituation that I mentioned, but also help to address anxiety and stress. So someone may prefer an in-person therapist, which is great. If we work with in-person therapists, we prefer to have someone who has some knowledge of tinnitus, and that may mean we educate them regarding our tinnitus patients, or the tinnitus patient educates them. We also know that we've had great success with digital therapeutic programs. One of those options is something called Auto. Even though it's pronounced Auto, it looks like Odo. And it provides cost and time-effective treatment that can be offered through an audiology or otology clinic. And it's very, very efficient. And they've just done a study with Auto, and it looked at the outcomes compared to what in-person CBT might find. And the DEFINE study, or the DEFINE trials, were just completed in the US. And what they show is it's very, very similar outcomes to people who use in-person CBT. So then we have to think about sound treatment. And this can be offered in a number of different ways. And Dr. Song mentioned that when someone has hearing loss, when we fit hearing aids, we're not just focusing on the hearing loss, we're focusing on the tinnitus. Patients will often say, I don't understand why I need to have a hearing aid. And we are trying to replace the information that the brain is missing. What we have found is that 60 to 70% of patients with well-fit hearing aids demonstrate a reduction in tinnitus perception. I just had a delighted patient with that in my office this morning. We know that well-fit hearing aids require something more than just putting the hearing aid on. They require us to use a verification method, which many audiologists talk about as real ear. And that has to be done to be assured that we are putting in the appropriate amount of amplification and also feeding the brain what it needs. The model that Dr. Song just talked about was also proposed by Dr. Jasterboff, and it's called the neurophysiological model of tinnitus, very, very common. Additionally, many hearing aids have built-in habituation options directly into the hearing aid that the patient can control and use. The latest issue that we've got going on with sound treatment is a new to the US device as of April 2023. It is called Linear, and it's a very new approach to looking at tinnitus using neural modulation, also discussed by Dr. Song. And what it does is it does bimodal stimulation, stimulating the trigeminal nerve at the base of the tongue, And you'll see that with the gentleman having the tongue tip in his mouth and a set of headphones which stimulate the eighth nerve. They've done a lot of research on this. As a matter of fact, I've been doing tinnitus treatment for 40 years, and this is probably the most researched device that has been around. It is the only FDA-approved device in the United States. It has a 90% success rate in reducing tinnitus perception, and it improves listening over tinnitus, sleep, concentration, in addition to reducing tinnitus loudness. So it's a device that's kind of a new tool in an armamentarium or toolbox of looking at tinnitus patients. Currently, this device is not available in Korea. And one of the things that I would say is that there are many kinds of sound treatment devices on the market. And I'm going to end a little bit by saying it's not the process, but the product. The skill of the audiologist that's fitting a sound treatment device is critical. As I mentioned with hearing aids, it's more than just putting the hearing aid on the ear. It's really being able to say, this is well fit, and 60 to 70% of those people are able to get benefit from that. And we know that the combination of counseling and sound therapy has a very strong evidence base. The goal for us is habituation that enhances the patient's feeling of being heard and giving hope in the interdisciplinary assessment. And I truly believe that the strength of doing that is in the partnership of otology and audiology. Thank you for your attention.
Thank you, Dr. Whitelaw. That was outstanding. And I completely agree. I think you hit the nail on the head when you said we have an armamentarium. We have a toolbox of treatments for tinnitus, that there is no one size fits all when it comes to treating patients with tinnitus. You have to modify and change, and sometimes do a little bit of trial and error to figure out what works best for patients. Absolutely. Again, if you have questions for Dr. Whitelaw, please be sure to put them in the chat on our YouTube channel. I also wanted to remind you that the webinar is being closed captioned on our AOS website. Let's take a minute or two and check out a few comments or some where people are tuning in from. I saw Egypt come through the comment section. Pretty amazing. This is all over the world. Lots of great questions. I promise we'll get to the questions at the end. The issue is that we want to present all the data, and then we'll have a good amount of time at the end for questions. And to ensure that we do have a good amount of time for questions at the end, let's move on to our next speaker, Dr. Jae-Jin Song, professor of otolaryngology at Korean University, who will present on digital therapeutics and electroceuticals for the treatment of tinnitus. And again, if you have questions for Dr. Jae-Jin Song, please type it in the chat and we'll get to it at the end of the presentations. Dr. Song?
Hi, Brett. Thank you for your kind introduction. Hello, everyone. I'm Jae-Jin Song from Korean University. And actually, I'm ENT clinician and also the founder and CEO of NeuRive, a Korean startup developing a non-invasive vagus nerve stimulation device and digital therapeutics for the treatment of tinnitus. In Korea, sometimes we prescribe medicine to the tinnitus patient, but unfortunately, more than 80% of patients are not satisfied, and about 40% of patients answer that the medication is not responding at all. It means that tinnitus is a disease very difficult to treat. And why is it? Why is the tinnitus difficult to treat? I think it's because tinnitus is not the matter of the ear only, but also the matter of the brain. For example, if there is any small lesion in the ear, it results in the loss of lateral inhibition in central auditory pathway, and finally, it causes a hyperactivation of auditory cortex. And we call it maladaptive plasticity, and that's the reason why we have to focus on the brain and ear together. Also, many of the tinnitus patients are suffering from anxiety, depression, and insomnia, and they are related with auditory limbic dysfunction. And these symptoms are also closely related with the prefrontal cortex and limbic system, as we know. So, to control tinnitus and associated symptoms such as depression, anxiety, and insomnia, we have to understand the brain more, and we have to find a way to control the prefrontal cortex and limbic system. Vagus nerve is 10th cranial nerve, which is responsible for the autonomic nervous system control of the internal organ of the body trunk, and it is connected with nucleus tractus solitarius, and it has a huge projection to various areas of the brain, including prefrontal cortex and hippocampus and amygdala and other limbic system structures. And it is well known that vagus nerve stimulation can increase neurotransmitter, cerebral blood flow, and alter EEG, neural activity. And finally, it can increase the brain plasticity. There is an auricular branch of vagus nerve on the right side here, a green color area, including external auditory canal, concha, and tragus area. And it is directly connected with nucleus tractus solitarius, which is responsible for the neuromodulatory effect of the vagus nerve stimulation. So, by electrical stimulation of this area, we can safely and effectively activate the brain, especially the prefrontal cortex and limbic system. So, there are many papers about vagus nerve stimulation and tinnitus. In this paper, invasive vagus nerve stimulation device was applied to chronic subjective tinnitus patient, and after 6 weeks of treatment, paired vagus nerve stimulation group showed improvement of tinnitus compared with control group. And in this paper, transauricular VNS was applied to chronic subjective tinnitus patient using this TENS device. And after 10 sessions of treatment, tinnitus handicap inventory was decreased from 49 to 40, 17%, and depression and anxiety was also significantly improved. And in this paper, transauricular vagus nerve stimulation was applied to tragus area using their own device. And as you see here, many tinnitus patients were suffering from insomnia and anxiety, which are related with hyperactivation of sympathetic system. After treatment, they measured heart rhythm variability and they found that HRV was improved. It means that parasympathetic tone was activated. After 1 year of treatment, tinnitus loudness, annoyance, and tinnitus stress was improved. So we have developed a non-invasive transauricular vagus nerve stimulation device. It is composed of main body and wired headset, and there are 2 electrodes each of the ear. By these 2 electrodes, we can deliver electrical stimulation and sound stimulation together. It is a personal wearable device, so the patient can treat themselves at home, whenever, wherever they want. In the US market, there is a transcutaneous transcervical vagus nerve stimulation device approved by FDA for migraine headache. And by fMRI, we compare the brain activation effect and bilateral simultaneous transauricular vagus nerve stimulation. We found that a prefrontal cortex and limbic system was activated. And this area is closely related with emotional control and cognitive process. Actually, we are collaborating with Dr. Felipe Fragoni and in Spalding Rehabilitation Hospital, Harvard, Boston, and we have cleared several clinical research trials. In this paper, before and after single session stimulation, we measured the heart rhythm variability, and we found that HRV was improved in active group compared with sham group. And this improvement was prominent, especially in aged population subgroup. It means that TAVNS can reverse the senile change of autonomic nervous system. Recently, we just have finished the pilot study for KFDA medical device approval for insomnia. After 6 weeks of treatment, at 3 and 6 weeks, the PSQI score was improved in active group compared with the sham group. And we are conducting pivotal study in Korea now. And also, we just have finished first pilot study for Korean medical device approval for tinnitus. It was double-blind RCT composed of 3 arms. And after 8 weeks of treatment, THI and TFI score was significantly improved in active group compared with the sham group. And also tinnitus distress and back depression index was improved in active group compared with the sham group. So based on this result, we are conducting a pivotal study for medical device approval in Korea. And by the end of this year, we will be able to report the final result. So this is my take-home message. Tinnitus is disorder of the brain, not just the ear, sharing its circuit with anxiety, depression, and insomnia. So we need to understand brain more, and we need to find smarter solution to modulate brain and ear together. And I believe that the transauricular vagus nerve stimulation can offer a safe and effective and non-invasive way to target these 2 networks, and can be a promising solution for tinnitus in the near future. Thank you for listening.
Thank you very much, Dr. Song. It's fascinating work. And again, to our audience, if you have a specific question to one of our panelists specifically, please type the name of the panelist in the chat on the YouTube channel. If it's a general question or comment, feel free to ask that as well. And let's take a look at some of the comments that are coming through on the chat. Hello from Boston, Massachusetts, hoping to hear about treatments or studies in the Boston area. Nashville, Tennessee, coming through. My tinnitus came after an acoustic reflex test and was made worse by an MRI scan. I cannot sleep and cannot think straight. I think you have lots of people who empathize with you. From the San Francisco Bay Area, does tinnitus cause headaches or vice versa? There's certainly potentially a relationship between tinnitus and headaches. We do have closed captions. Closed captions are on the American Otological Society website at americanotologicalsociety.org. Thanks for tuning in. And if you can find the AOS or American Otological Society website, you'll find closed captions. Insak Moon, thank you very much for the informative lecture. I appreciate your comments. A listener from Pennsylvania, listener from Palm Springs, California. Good afternoon to you. Great lecture. Thank you very much. That was from Korea. Viewer listening in from Michigan. Hi from St. Petersburg, Florida, Todd and Kristen Bourdignon. I think those are familiar folks to those of us in the American Otological Society. Thanks for tuning in, Todd and Kristen. All right. And so the Q&A will follow our final presentation of the evening by Dr. Greg Basura, who is professor and director of global outreach in the Department of Otolaryngology, Head and Neck Surgery at the University of Pittsburgh Medical Center. His talk is entitled Objectifying a Subjective Problem, Shining a Light on Human Tinnitus. Dr. Basura? Great.
Thanks a lot, Brad. I really appreciate the opportunity to speak tonight. I'd like to thank the AOS and the KOS for allowing me to shine some light on some of this work that I've been doing that spans a couple of universities that started over a decade ago at the University of Michigan, and then I brought it here to the University of Pittsburgh. As we attempt to objectify this subjective problem using some innovative neural and brain imaging. I have no disclosures. So as my colleagues have elegantly showed tonight, we demonstrated that tinnitus is a perception, is a brain phenomenon, and it's incompletely understood. There's many mechanisms, as you can tell. The most common that we deal with is this altered input into the brain from the ear, which usually comes in the form of hearing loss, or this subjective form of tinnitus. What's emerged over the last couple of decades, though, is that there's multiple flavors of tinnitus. And one of them that has really emerged and has taken hold within the literature is this aberrant somatosensory inputs that I worked on in the lab of Dr. Susan Shore as a fellow at the University of Michigan, where we understood that the spinal trigeminal tracts feed not only into the brainstem auditory nuclei, but also directly to the auditory cortex through non-lemniscal pathways. That when aberrant, for example, in someone's TMJ, cervical spine injury, dental work, can actually cause tinnitus in the absence of hearing loss. So at the heart of this is what we look at as a disinhibition of ascending pathways within the central circuits. And elegantly, Dr. Shore, Dr. Xenopoulos here at Pittsburgh have used animal models and elegantly shown that there are neural correlates of tinnitus in the animal brain. These come in the form of increased spontaneous firing rates, where neurons are firing spontaneously, and then they fire together. So this idea of misery loves company. So now not only are these circuits firing on their own, there's an additive combination of neurons firing together, which can increase the percept. What's currently missing, though, is how are these neural correlates found in the human brain, and are they translated? Well, what's happened recently in an attempt to try to correlate this is we've had limits of imaging availability. Things like fMRI and PET scans have limited abilities to measure the brain because they can confound the recording environment in the form of noise that an fMRI makes, or repeated radio tracer for PET studies that limit the reusability or the use in younger folks. So 10 years ago at the University of Michigan, I discovered that FNIRS, or functional near-infrared spectroscopy, which is really a giant pulse oximeter for the brain, which measures oxygenated and deoxygenated hemoglobin changes in the presence or absence of activity. From this, we can use this as an indirect measure of neural activity or the hemodynamic response. So a decade ago, I went to work with this with initial hypothesis of, can we replicate these neural correlates in humans, looking at increased spontaneous firing rates and maybe an equivalent of neural synchrony. So what you see here on the left-hand side is the first paper we published in 2016, which we then validated in 2020 with an adapted probe for the ear canal, in that we showed that in the ROI, the auditory cortex, in the absence of sound, there's a basal maintenance of activity of the auditory cortex that also transcends the auditory cortex and is found in adjacent non-auditory cortices, which was really exciting. Interestingly, when broadband noise is introduced to the circuit, we see a suppression of that activity. This might be akin to a forward masking phenomenon that also goes outside of the auditory cortex. So when we first saw this, we were extremely excited because this showed for the first time using this imaging modality that the auditory cortex, like the animal model of tinnitus, has a heightened activity on its own. The second correlate was, can we show something akin, the macro correlate of neural synchrony? Well, we can also measure resting state functional connectivity with FNIRS. And this is looking at, are these areas connected? Are there pathways that now are unmasked, latent pathways that now become disclosed? And sure enough, looking across these cortical regions in the tinnitus brain, which is the bottom right-hand triangle, as opposed to the control on the top left, we see with the warmer colors increased functional connectivity in the tinnitus brain, suggesting that it's communicating more broadly outside of the auditory center into non-auditory regions. And we validated that again with two separate publications, suggesting that now the tinnitus brain has a network in which there may be etiology occurring that occurs outside of the main central pathways. As I move forward into my current role here at the University of Pittsburgh and our new R01 funded study, we're now looking at, and we've replicated nicely in the absence of sound, the elevation. You're looking at a hemodynamic response across time. The green lines off baseline suggest in both the ROI, which is auditory cortex, and non-ROI, that those brains are active. They are active in the absence of sound, and this is akin to increased spontaneous rates. Interestingly, to validate our studies, we actually showed again that in the sending of broadband noise that we can suppress that activity. And this may be some form of the masking benefit we see. But what we've extended with these studies is, does this correlate with subjective reporting? And what's interesting is we do find that is the case. When we look at our hemodynamic responses, our HBO, and we compare that to our mean THI, which my colleagues have mentioned as the Tinnitus Handicapped Index, we see a positive correlation across the board that those with higher rates of THI correlate with objective change that's commensurate with that subjective reporting. This is really exciting because this can move us forward to better understand with predictive modeling those patients that might have higher levels of tinnitus. They might have predictive changes in the brain that we can then think about as we design therapies going forward. Now, if we move our gaze from into the second realm of tinnitus that we're looking at in the second part of this grant is looking at the vibrotactile component, or the somatosensory or somatic tinnitus. What we've done here is we've looked at stimulating spinal trigeminal tracts in control and tinnitus subjects, in normal hearing subjects that can modulate their tinnitus in the absence of hearing loss. And we've shown, interestingly, in the purple line that in response to vibrotactile stimulation at the neck, we can increase hemodynamic response alone, suggesting that those pathways feed all the way forward to the auditory cortex, as we looked at in animal models in the distant past. And in silence, we have a decrease as we expect. Interestingly, this is a pooled non-ROI, which includes some of the frontal areas and occipital areas where you see that somatosensory stimulation can also have an effect. Now, what about in tinnitus? This is what's fascinating. This is data that we just have uncovered as we move forward into this grant cycle. And we've shown now what's fascinating in the tinnitus is that, again, we've replicated once again with the green line. We see an increased hemodynamic response in silence, akin to the increased spontaneous activity at the cortex. But now look what somatosensory stimulation does to that spontaneous rate. It completely blunts that. This not only blunts it in the auditory cortex, but it does this outside of auditory cortical areas in non-auditory areas, suggesting that this somatosensory mechanism reaches beyond this. And this, again, may be an indication of some of the networking we're seeing as the functional connectivity of the brain has changed in tinnitus. Now, some of these pathways coming up from subcortical areas from the brainstem might have broader reaching areas across the cortical the cortical areas that may be of clinical significance. Now, what's fascinating is in these same subjects, broadband noise also plays a role in suppression, as it does in folks that have non-modulatable tinnitus, suggesting that in the heightened, again, spontaneous rate in the cortical area and non-auditory areas, there is suppression by broadband noise, suggesting that in folks that have purely somatosensory tinnitus that can modulate it, broadband noise also plays a role of this. And this leads us to believe into this idea of bimodal stimulation, which was studies that I did in the animal models looking at somatosensory paired with auditory stim, and how the idea of spike timing dependent plasticity may actually change neural pathways. So going forward, FNIRS can repeatedly, reliably detect hemodynamic responses in resting states. We found that these areas can be suppressed with broadband noise, and that we see changes in resting state connectivity, all changes in the brain that can be maladaptive. We now feel like we're building a strong case that hemodynamic responses in resting states serve as tinnitus correlates in the human brain, akin to the animal models, and that we are now seeing that subjective reporting correlates with those changes. Going forward, we're seeing that the somatic tinnitus can be suppressed by not only somatosensory inputs, but auditory stimulation. That can be really important as we design treatment options going forward. And as I'm moving forward into the next phase of the research component, we're now going to be combining FNIRS with EEG, which gives us not only spatial components of where things are occurring, but also gives us some timing of these effects, which will be important for treatment options. So I'd like to thank all the people that have been involved with this work over the years that spans University of Michigan, now University of Pittsburgh. And if you're interested, please go to my lab website where you can get more information about what we're doing. Thanks for your time.
Dr. Basura, thank you very much. That's great work and exciting to see what the future holds. Don't go anywhere. We have a really interesting question for you. And so, at this point, we now turn to you, the audience, to ask questions. And if you don't have a question to ask, that's okay too. Leave us a comment. Let us know what you felt about, or how you felt about the webinar. But Greg, does vivid dreaming, this is a question from Seattle, does vivid dreaming increase neural activity in a way that could trigger tinnitus in the brain?
That's a fascinating question. I've never actually been posed with that question. One of the things that's interesting, it's timely in that we are moving into EEG, and EEG is an important component to looking at neural responses because it can map timing of neural response. And one of the ways that you do EEG is with eyes open, with eyes closed, because it impacts the neural response patterns. So in fact, we will be looking at combining NIRS with EEG in those circumstances. Now, we'll have patients with eyes closed during that component. They probably won't be having vivid dreams. And so I don't know if that's going to change anything, but I honestly don't know the answer to that question, but I think that's a really interesting point that may warrant looking into.
It dovetails well with your research. Thank you very much from Seattle. Let's bring on all the panelists and let's open it up to the Q&A. Jae-Jin, what are your thoughts?
It was a fascinating symposium. Well, of course, as one of the speakers, I'm the last person you should trust on this, but it was a meaningful night. And if everyone leaves thinking it's not my ears, it's my brain, then we did our job. Thank you.
Beautifully put. A lot of the comments were about getting into a clinical trial for tinnitus, and some of the comments asked for specific clinician practitioner recommendations. If you're interested in clinical trials for tinnitus, go to the website www.clinicaltrials.gov. That's www.clinicaltrials.gov. That is the United States government's clearinghouse for all its clinical trials. You can enter tinnitus. Now, as far as a specific practitioner to recommend for the treatment of tinnitus, we can't make any specific practitioner recommendations. However, if you go on the American and/or Korean Otological Society's websites, you'll be able to find names of practitioners that will be able to help you. These are fellows of the American Otological Society and fellows of the Korean Otological Society, well trained in diseases of the ears. So I think that would be a good first step in finding a practitioner that has an interest and experience and expertise in treating tinnitus. Several of the questions talked about medications. Can medications increase tinnitus? Can medications reduce tinnitus? Dr. Jae-Jin Song, tell us about your experience with medications, either making tinnitus worse or making tinnitus better.
Usually, I prescribe the medicine to the tinnitus patient, and more patients experience a improvement of tinnitus by medication. But some are, especially those who suffer from insomnia or depression, those are responding to the conventional medication much better.
And Dr. Basura, experience with medications?
Yeah, so I don't prescribe any specific medications to treat the tinnitus. One of my main questions I always ask a patient is, how is the tinnitus affecting their mental health? Number one. And then I address that primarily first. I always try to remove medications that might be causing that in their life. I ask about use of high doses of aspirin, high doses of nonsteroidals, and then some of these associated medications. But I don't have a specific medication that I'm actively prescribing.
There's a question from Florida. Had tinnitus most of my life, but got much worse and constant after a fall. Do any of you have experience with trauma, head trauma, and tinnitus? Let's go to Dr. Whitelaw first.
I actually see many, many patients with traumatic brain injury, and the body of literature talks about tinnitus being one of the most common auditory symptoms, more so than hearing loss. And certainly people will develop in conjunction with that sound tolerance issues. Unfortunately, many patients head injury patients, concussion patients, aren't referred to otologists or audiologists, so it may take them a long time to get to that point, but that's a very commonly reported issue after a head injury.
Let me stay with you for just a second, Dr. Whitelaw. Noise canceling technology. Do you have any experience with noise canceling headphones and the treatment of tinnitus?
Yes, I do. And it's not found to be particularly very effective. I think for people who may have some sound tolerance issues where sounds that sound typical to us are really disturbing to them, may do a little bit better with noise canceling headphones. But certainly there's not much evidence that noise canceling headphones alone work effectively for tinnitus treatment.
Dr. Jae-Jin Song, any experience with noise canceling headphones?
personally, I don't have any experience of noise canceling headphones for treating tinnitus, but I don't think it might be very effective in treating tinnitus. It might be effective, of course, for treating hyperacusis.
Right. How about psychiatric drugs? Any experience, Dr. Basura, with psychiatric drugs either causing tinnitus or accelerating it?
Anecdotally, I've seen, in patients that may be taking medications like this, that they may have exacerbations in tinnitus, and they may come in with tinnitus. It's really challenging to determine the cause and effect on that because of frequency of use or infrequency of use, as well as dosing. So it's a challenge there to kind of pin that down. But I've seen that anecdotally, yes.
A couple of specific questions for Dr. Whitelaw. Why does it seem like my hearing aids are amplifying my tinnitus symptoms?
That's a really tough question to answer because, again, what I was talking about is if hearing aids are not fit, I call it exquisitely. Oftentimes it will do that. So I think that's a really great question for whoever fit your hearing aids to go back and say, hey, let's focus on my tinnitus for a little bit, because many audiologists are focused on what all of us have talked about tonight, the hearing loss. And using that real ear verification is something you can ask for. And we've often found that just a little tweak in that verification with the amplification will make a huge difference in the treatment. So I would encourage you to go back and talk with your audiologist and let them know that you feel like your tinnitus symptoms are a bit worse with the hearing aids, and see if there's a little tweak that can be done to improve that for you.
Just as a follow-up, I often counsel patients on the benefits of hearing aids in tinnitus, because hearing aids bring in a little bit of background noise and mask or drown out the patient's own internal tinnitus. Is that a successful strategy?
It's a very successful strategy. And again, exquisitely fit hearing aids. You're absolutely right, Dr. Kesser. 60 to 70% of people will say that they have a big improvement. The difficulty is when patients go and they've heard this and they get hearing aids, I guess, for a lack of a better term, slacked on, and they don't give any feedback to their audiologist. And what I found is a lot of patients are afraid to give feedback. And one of the things that we work with is we want them to give us a lot of feedback. If it's not addressing your hearing loss, if it's not addressing your tinnitus, I want to know about that so I can make some changes, because modern day hearing aids do amazing things and have amazing opportunities. And you're right, the digital hearing aid age, the advanced technology age has allowed us to do things that we couldn't do when I first became an audiologist with hearing aids.
Thank you very much. The mom, Heather, says, I have worn hearing aids for 22 years with tinnitus as I lose my hearing. I'm going deaf. What is there for someone like me? The possibility of being deaf with tinnitus is scary. I can completely empathize. It's very, very scary. I'll ask the panelists, how would you answer Mom Heather? Dr. Jae-Jin Song first.
Yes, I think that tinnitus itself does not cause the hearing loss. On the contrary, hearing loss can worse than tinnitus. So I'd like to reassure the patient that you don't have to be scary so much like that. And if you lose hearing more and more and became deaf, cochlear implantation would be one of the options in that situation.
Thanks, Dr. Song. I was going to pose that to Dr. Basura. Greg, what's your experience with cochlear implants in tinnitus?
It's been very positive. Yeah, I think that most patients, they come in with different motivations for obviously cochlear implantation if they get to that level. Many of them, the hearing actually can be driven by a spouse or a family member, but they want to just mask the tinnitus, right? So sometimes there's a different motivation, but the outcomes that I've experienced over the years are very positive with suppression of tinnitus. Now, it's not 100%, and I'm very obviously frank with the patient about that. But I always tell them that I'm optimistic that you'll get at least some dulling or some suppression of the tinnitus. I can't obviously predict without, future data and research, but it's been very positive.
Good. Jae-Jin, would you say the same?
Yes, tinnitus it can be very successfully suppressed by restoring your auditory input, and that's why post-lingual deafness, patients who lost their hearing after developing the language their tinnitus can be much improved after wearing the cochlear implant.
It's interesting that one of the earliest indications for cochlear implantation in single-sided deafness, so these are patients who have lost hearing in one ear but have normal or near normal hearing in the other ear, the early indication was cochlear implantation to suppress the tinnitus. The tinnitus was so bad or so debilitating in the deafened ear that we, some bold researchers and bold surgeons decided, let's put a cochlear implant in a patient with single-sided hearing loss. And sure enough, it was one of the reasons why cochlear implantation was approved for single-sided hearing loss. So I think that was a major step in our advancement of candidacy criteria, certainly for cochlear implants. Let's see. Dr. Whitelaw, here's a good question on Linear. Lots of comments on the Linear device not being as successful as advertised. Can you speak to proper use of this technology?
Sure. We've fit about 500 Linear in our clinic so far. I was one of the first 14 in the US to be able to fit them. And I can tell you the things that make a good candidate is somebody who comes in and is going to do it consistently. It has to be done daily. It has to be done for an hour a day. It has to be done with great compliance. It is best used when we're using it with a cognitive behavioral therapy program at the same time. So kind of giving it a 1-2 punch to be able to go after the tinnitus. I have a patient who started Linear, and we know that probably about, somewhere around, 90% of people do find benefit from it. But benefit does not mean a cure. And a lot of people who are looking at Linear want that cure. I have a patient who came in last week, and we know that the original data out of Ireland, the 6 to 12 weeks, isn't consistent with what we see in the US. I think we've taken more difficult patients. And, the question was, it wasn't effective after 12 weeks. There are tweaks that we can do on it, but that consistency, I will tell people up to 20 weeks, we still start to see the beginning of improvement. There's a lot written on the internet about Linear, and it's hard, the internet is one of those places it's hard to get information from because we don't know what's true and what's not true. And there are people who, like my patient, who used it for 4 days and told me it wasn't working for him. So I think it's really important to, if you want more information about Linear or you're having difficulty with a Linear fitting, to talk to a Linear provider who has experience with the device, more than 1 or 2. And there are a lot of people in the US, a lot of audiologists in the US who have significant experience with it, and we'd be willing to talk with you about that.
So the take-home message is you just got to have to stay with it and keep at it, and it will show effect, but it's not going to be an overnight miracle.
Absolutely.
Question for Dr. Basura. When will the Dr. Shore bimodal device be available to the public?
Yeah, that's a great question.
Tell us what the device is first, and then let us know what its status is.
Yeah, so this is what's on the heels of the Linear device. So when I was at the University of Michigan, the Dr. Shore's lab, the idea of bimodal stimulation was this concept of spike timing dependent plasticity, that if you can control stimulation of the circuit into the brainstem, both somatosensory and auditory, depending on the order of the input into the brainstem and the timing interval, we could drive neural activity up or down akin to what's called long-term potentiation or depression. So the idea is we did a couple of trials. One was published in Science Translational Medicine, utilizing optimal long-term depression parameters in animals with a device that was built to provide non-invasive stimulation into those circuits. And it showed that you could suppress tinnitus out to a certain, to a short-term degree. So that's moved through some of the commercialization processes now, and I think it's still being worked through some private corporations that have taken over some of the intellectual property. I don't know exactly the details of that or where that's going currently, but that intellectual property is still being sort of worked up. I hope one day it will be, because it showed to be effective, at least experimentally. And it's actually the foundation of some of the work I'm doing now with NIRS, because now I can do these stimulation trials peripherally, but now I can measure with an objective measure with NIRS is what we're utilizing. So it's really exciting, but I don't have an answer yet, but I'm hoping in the near future.
Great. Thank you very much. I know we're over the hour, but the response has been so tremendous that if it's okay with you all, we'll keep throwing a couple of questions more, and then we'll wrap it up. Are there any cell phone apps that have been successful in making sound modulation therapy more accessible? Let's go with Dr. Whitelaw.
There are patients who anecdotally say they use cell phone apps. A number of the hearing aid manufacturers also produce free cell phone apps. And so Widex, W-I-D-E-X, is one of them. They use a product called Zen, and many of my patients use that for sleep. And then Resound, R-E-S-O-U-N-D, has a relief app. Those are both free. They've been vetted by the hearing aid manufacturers, and some of them are actually in hearing aid products. I have patients who use everything from brown noise to pink noise that they find on their phone. And the Calm app has some great options. We're looking at some research right now on EMDR, and you can use that binaurally or bimodally. And the Calm app uses EMDR to help relax, but also I have tinnitus patients who sleep with that. So yes, there are some good app options out there. One thing, if you're going to use an app, I prefer that you use something like a sound pillow, or you can get a Bluetooth speaker that fits under your pillow, really inexpensive, and it delivers it right to your ear. One of the complaints we hear from spouses is they don't really want you using an app all night long when they're sleeping in the same bed as you. They don't want to hear rainfall or brown noise. So there's some really nice options that you can deliver it directly to your ear and make that work very effectively.
Thank you. This is an interesting question. Dr. Jae-Jin Song, is there a link between the gut microbiome and tinnitus? And if so, can probiotics help tinnitus?
That's a very interesting question. We don't have enough data as far as I know, but if the gut microbiome can improve the patient's condition, then it might be of at least a little help to the tinnitus. So patients who have very higher sympathetic nervous system tone, their tinnitus worsens. And on the contrary, if you make your sympathetic tone like less active, then your tinnitus improves. And that's why if you have mental stress or physical illness or sleep deprivation, your tinnitus worsens, and vice versa.
Thank you. Let's take one more question, and this is for Dr. Jae-Jin Song. My tinnitus cycles. I have days where it's loud and days where it's calm and I hardly hear it at all. What's going on?
Yeah, there are so many patients like that. So in that case, I ask question, how was your sleep, and how was your mood, and how was your physical activity or illness? In that case, most of the patients answer that I couldn't sleep. I was sleep deprived, or I was sick for some reason. And after that, a patient realize that tinnitus is worsened. But in some patients, they don't realize that their tinnitus is related with emotional stress or mental or physical stress. So one of the role of the clinician is to get insight to the patient that the tinnitus is not the physical matter only, but also the mental or psychological issue. So by just realizing that relationship, patients feel much better and relieved.
And Brad, can I add something to that, if that's okay?
Yeah, please do.
One of the things that's interesting that I always ask all my patients is there anything that you do that makes it better or worse? I don't bait patients, but many will say, no, if I move my head and neck, if I bite my teeth, if I jet my jaw, it gets worse or goes down. Many times people will have nocturnal bruxism. They grind all night in their sleep. They'll wake up with rip roaring tinnitus, and then it'll bait during the day because they're not clenching or grinding in the waking hours. And so I always ask them about timing of that and if they have those issues. So that can sometimes explain why you see some cycling qualities to the percept.
Thank you very much. Well, I thank all of you in the audience for participating in this lively panel on tinnitus. And of course, I thank all of our panelists, Dr. Greg Basura, Dr. Gail Whitelaw, Dr. Jae-Jin Song, Dr. Jae-Jin Song. Really appreciate all of your insights. Thank you to Nancy Young and Dr. Nancy Young and Dr. Shine Park, the presidents of the American and Korean Otological Societies, who kicked off today's webinar. Well, Jae-Jin, as we close in on the hour and the end of our webinar, anything else to add?
Thank you all so much for joining us today. I'd like to extend my sincere gratitude to the AOS, the American Otological Society, and the Korean Otological Society for hosting this joint webinar, and to everyone who worked behind the scenes to make it possible. Most of all, thank you to our audience for your time and attention. Thank you for tuning in.
I would say I am heartened by this webinar. For a condition in which we doctors used to say, go live with it, there's nothing we can do about it, it's really uplifting to know that we have people interested in researching the causes and underlying mechanisms of tinnitus. And through understanding the mechanisms of tinnitus, we can develop new and exciting treatments for tinnitus. It is through this research where we will find treatments and treatment strategies to help our patients manage and cope with their tinnitus, even if we can't cure it in the pure sense of the word. Truthfully, I think the day we find a cure for sensory neural hearing loss, and that day will come, it's not tomorrow, but it will come, I think that will be the day that we cure a lot of tinnitus. To the doctors in the audience, both the MDs and the AUDs, I hope you have taken away one or two pearls to help your patients manage their tinnitus, or at least the reassurance that there are some very smart people researching this challenging symptom. And to our patients and to our audience, I hope this webinar gave you hope that doctors are working assiduously to understand tinnitus and help those who suffer with it. In closing, we hope you all have enjoyed this webinar, and on behalf of the American and Korean Otological Societies, we thank you for tuning in. Thank you to our panel of experts, and I'd like to thank our producer, Neil Perek, and his team from Digimentors. Good night, or have a good day, depending on where you're listening.